So the next question, Addison's disease is characterized by all except. The options are the hyperglycemia, hypotension, hyperkalemia, then the hyponatremia. So what is that you will not have in patients with the Addison's is hyperglycemia will not be there. Why? Because in case of Addison's, there will be decrease in steroid levels. So as there is decrease in steroids, the gluconeogenesis decreases, and thereby these patients, they will be having hypoglycemia but not the hyperglycemia. And why is that they have hypotension? The hypotension in patients with the Addison's, it is due to steroid deficiency, and it is also due to the aldosterone deficiency, right? So it is due to both steroid and as well as aldosterone deficiency, the individual will develop the hypotension. Next is the hyperkalemia. What is the cause of hyperkalemia? The cause of hyperkalemia, it is again the same, that is due to the aldosterone deficiency. These patients will be having the hyperkalemia. Next, coming to the hyponatremia, that is again because of the aldosterone deficiency, because the aldosterone is the one which is required for the sodium and as well as water retention, and once there is aldosterone deficiency, that will result in the development of the hyponatremia. So Addison's is characterized by all except what? The hyperglycemia will not be there. And what is the most common cause of the Addison's in India? That will be tuberculosis. And most common cause of the Addison's in the West, that will be autoimmune adrenalitis, right? That will be autoimmune adrenalitis. And the next important fungal infection that will be causing the Addison's will be histoplasmosis, right? That will be the fungal infection that will be causing the Addison's. And we also have the viruses, that is HIV and as well as cytomegalovirus, that will be or that will contribute to the development of the Addison's. And apart from these particular infectious processes, we also have the infiltrative disorders that will be causing the Addison's. And these infiltrative disorders will be, number one, the hemochromatosis, then sarcoidosis, which is characterized by accumulation of non-caseating granuloma within the adrenal gland, right? And next to the sarcoidosis, so hemochromatosis is one and sarcoidosis is one. These two are the important infiltrative disorders. And then we also have an X-linked disorder that is called adrenomyeloleukodystrophy. So in case of the adrenomyeloleukodystrophy, right, in case of adrenomyeloleukodystrophy, which is an X-linked disorder, this is more common in males rather than females, right? This is more common in males rather than females. And in patients with Addison's, you have everything being decreased, aldosterone being decreased, corticosteroid being decreased, and weak sex hormones are also being reduced. So this is about the Addison's. And in case of Addison's, what is the investigation of choice? The investigation of choice will be the 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 test, right? The 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 test, or this is also called as the ACTH stimulation test, right? This is also called ACTH stimulation test. And what exactly is the drug of choice in case of the Addison's? The drug of choice in case of the Addison's will be the hydrocortisone. So hydrocortisone will be the drug of choice in case of the Addison's, right? Next question. The most common cause of the Cushing syndrome is, the options are the pituitary adenoma, then the adrenal adenoma, then the ectopic ACTH, and then the iatrogenic steroids. So if you take the most common cause of the Cushing's, as such the most common cause of Cushing's is the iatrogenic steroid supplementation. But if the question is asked most common cause of ACTH dependent type of Cushing's, then it will be pituitary adenoma, and that too it will be a corticotroph type of the pituitary adenoma, right? And what is the most common cause of the ectopic ACTH causing the Cushing's? Most common cause of ectopic ACTH causing Cushing's will be small cell carcinoma of the lung, right? That will be small cell carcinoma of the lung. Then most common cause of the ACTH independent type of Cushing's, most common cause of ACTH independent type of Cushing's will be adrenal adenoma, right? So this will be adrenal adenoma, right? And yeah, so these are the most common causes which are causing Cushing's. And we have one more important terminology called most common cause of Cushing's disease. When the term Cushing's disease is being used, please remember it is always the central pathology within the pituitary, that is the pituitary adenoma. So when term Cushing's disease is given, even though iatrogenic steroids are there, please don't mark iatrogenic steroids, it should be the Cushing's, it should be pituitary adenoma for Cushing's disease. But when the term Cushing's syndrome is being used, then the most common cause will be the iatrogenic steroid supplementation. Alright, then, and one more question they can ask you, that is most common cause of non-iatrogenic Cushing's. Right, the most common cause of non-iatrogenic Cushing's will be again the pituitary adenoma. Right, will be again the pituitary adenoma. So this is about the story related to Cushing's. Next, now investigation to be performed in a patient with hypertension and the hypokalemia, renin-aldosterone ratio, ACTH stimulation test, 24-hour urinary catecholamines, then the octrio scan. So hypertension and as well as hypokalemia, where do you come across this is mainly in patients with the 𝐶ON syndrome. So in patients with 𝐶ON syndrome, there will be hypertension. Along with hypertension, right, along with hypertension, these patients will be having the hypokalemia. So in patients with 𝐶ON syndrome, what happens is the aldosterone renin ratio will be increased, or your renin aldosterone ratio will get altered. That is the primary screening test in case of the 𝐶ON syndrome. Right? Then what is the investigation of choice in patients with the 𝐶ON syndrome? The investigation of choice will be oral salt solution or IV saline suppression test. Right, IV saline suppression test. That is what we do in case of the 𝐶ON syndrome. That is the investigation of choice. Whereas ACTH stimulation test is the test which is being done in the diagnosis of the Addison's. Whereas you take this 24-hour urinary catecholamines. 24-hour urinary catecholamines, they are used in diagnosis of the pheochromocytoma. Right, that is a screening test in case of the pheochromocytoma. Whereas in case of the pheochromocytoma, what is the way by which you can confirm the diagnosis is by estimating the plasma catecholamine levels. Right, by estimating the plasma catecholamine levels. Whereas if you take the octrio scan, it is used for diagnosis of the carcinoid syndrome. Right, for the diagnosis of the carcinoid syndrome, we do the octrio scan. So the answer here is the aldosterone renin ratio will be the answer for an individual with hypertension and as well as the hypokalemia. Right, next question. ACTH dependent Cushing syndrome is caused by pituitary adenoma, adrenal adenoma, adenocortical carcinoma, pheochromocytoma. Just now we were discussing. Now this ACTH dependent type of Cushing's, we classify that again into the pituitary adenoma, right? And one more thing is the ectopic ACTH production causing Cushing's. Now what are the sources for ectopic ACTH is, number one, small cell carcinoma of the lung, which is also called as the Ōt cell carcinoma. Right, which is also called the Ōt cell carcinoma. And what are the other sources for ectopic ACTH is, it also include the pheochromocytoma, right? And it also include the next important ectopic site, that is medullary carcinoma of the thyroid. Right, medullary carcinoma of the thyroid. And the other sites where you have the ectopic ACTH is pancreatic and as well as bronchial carcinoids. Right, pancreatic and as well as the bronchial carcinoids. Okay, so these are the sites for the ectopic ACTH. Right, so the answer here will be pituitary adenoma. That will be the best because that is the most common cause of ACTH dependent type of Cushing's. And the next best answer will be the pheochromocytoma. So ACTH dependent type of Cushing syndrome is or are caused by, that is pituitary adenoma and as well as the pheochromocytoma. Next question. Hyperpigmentation is seen with which hormone? Follicle stimulating hormone, luteinizing hormone, thyroid stimulating hormone, and as well as the ACTH. So the hyperpigmentation, it is mainly because of increase in the release of the melanocyte stimulating hormone. Now, as and when there is increase in the levels of ACTH, Parallelly, there will be also increase in the melanocyte stimulating hormone as well, and that is what is responsible for the hyperpigmentation. So hyperpigmentation is seen with which hormone? That is ACTH, because whenever the ACTH is being produced, there will be release of pro-opiomelanocortin, which is the precursor of the MSH, and this pro-opiomelanocortin is the one which will be converted into MSH, and that will result in the hyperpigmentation. So hyperpigmentation is seen with the ACTH. So the next question is, all are seen in the Addisons except. The options are hyponatremia, hyperkalemia, hypotension, metabolic alkalosis. Now in Addisons, you have the aldosterone deficiency, right? And what does this aldosterone does? Aldosterone does sodium and water retention, potassium excretion, and the H+ ion excretion. So this is what is the action of the aldosterone. Now, when aldosterone is reduced, the sodium retention does not occur. That will result in the hyponatremia. And when there is aldosterone deficiency, the potassium excretion does not occur. That will result in the hyperkalemia. And H+ ion excretion does not occur, and that will result in the acidosis. So this is what is the electrolyte changes that you will have whenever there is the aldosterone deficiency. So hyponatremia will be there, hyperkalemia will be there, and once there is aldosterone deficiency, water retention also will not occur, and that will result in the hypotension. But please remember, metabolic alkalosis will not be there. What they will have is metabolic acidosis, right? There will be metabolic acidosis. So this is what is observed in patients with the Addisons. Next question. Which of the following is the most common cause of Addisons in India? Just now we were discussing the postpartum pituitary insufficiency, tuberculosis, HIV, and autoimmune adrenal insufficiency. So tuberculosis, that is the most common cause in India, whereas autoimmune adrenal insufficiency, right? So this is most common in the Western countries. This is most common in the Western countries, right? Next question. Cushing syndrome is commonly caused by adrenal adenoma, adrenal hyperplasia, ectopic adrenal hormone production, and adrenal carcinoma. So Cushing syndrome, if you see in the options which has been given to you, it is adrenal adenoma. As such, Cushing syndrome is caused most commonly by iatrogenic, because that is not there in your options, so that is not there. And the next most common cause will be pituitary adenoma, even that is not there in your option. And the most common cause of ACTH independent type of Cushing's, that will be the adrenal adenoma. So it is commonly caused by what? That is adrenal adenoma. Next question. Cryoglobulinemia is seen with hepatitis C, diabetes mellitus, leukemia, and then the ovarian cancer. So cryoglobulinemia, it is commonly seen with the hepatitis C, right? So if you take hepatitis C, what are the extra in case of hepatitis C? Definitely yes, there will be development of the hepatitis, and this hepatitis will progress to the cirrhosis of liver, and that will progress to the development of hepatocellular carcinoma, right? And in case of the cryoglobulinemia, what is this cryoglobulinemia? That is cold precipitable immunoglobulins. That is what is called as the cryoglobulinemia. And what are the extrahepatic manifestations in case of hepatitis C is, in case of hepatitis C, the hematological manifestations will be in the form of the aplastic anemia, right? There will be decrease in the platelet count, and there will also be non-Hodgkin's lymphoma. These are the hematological manifestations. And endocrine manifestations, if you observe, that includes type 1 diabetes mellitus and thyroid disorders. And these thyroid disorders, they include the hyperthyroidism and as well as the hypothyroidism. And what are the connective tissue disorders that we come across in case of the hepatitis C is cryoglobulinemia, right, where you have a cold precipitable immunoglobulins, then polyarteritis nodosa, and next Sjogren's syndrome. So these are the connective tissue disorders that can be seen in hepatitis C. Now, if you take the cutaneous manifestations, the cutaneous manifestations, that will be lichen planus, then porphyria cutanea tarda, And the renal manifestations and CNS manifestations include Guillain-Barré syndrome and then glomerulonephritis, and miscellaneous conditions are sialadenitis. Okay, so these are the extrahepatic manifestations in case of the hepatitis C. So this essential mixed cryoglobulinemia, right? Where do you come across this? It is seen in patients with the hepatitis C. Next question. There are 3 to 5% of the healthy hepatitis B carriers in India who are asymptomatic. They have the risk of developing hepatocellular carcinoma in future due to, the options are inability to induce the inflammation against the virus, integration of the virus with the host DNA, increased liver transaminases, and fourth, high rate of the hepatocyte proliferation. So a patient with hepatitis B carrier will have increased risk of the hepatocellular carcinoma. That is because of integration of the virus, right? That is because of the integration of the virus with the host DNA. And integration of hepatitis B virus DNA, it is seen in more than 90% of the hepatitis B infected patients, right? And what is the gene in hepatitis C virus that will be responsible for the development of the hepatocellular carcinoma? That will be HBxAg or HBx gene, right? It is the HBx gene which is present in hepatitis B virus, that is a potent tumor activator, and that will be causing the hepatocellular carcinoma. Next question. Now, which of the following serum markers for liver fibrosis can replace the need for the liver biopsy? The options are SGOT, SGPT, serum hyaluronic acid, GGT and fibronectin and factor V levels. Now, the liver biopsy, it is an invasive process, and non-invasive method of estimating the liver fibrosis is the serum hyaluronic acid. The serum, what is exactly the serum hyaluronic acid? The serum hyaluronic acid, it is a glycosaminoglycan, and it is a component of the extracellular matrix, right? It is a component of the extracellular matrix that is produced by hepatic stellate cells. That is produced by hepatic stellate cells. Okay. Now, the degradation of, right, the degradation of the glycosaminoglycans occurs in sinusoidal endothelial cells, right? In sinusoidal endothelial cells, there will be degradation of the glycosaminoglycans, right? And the serum concentration of the hyaluronic acid is elevated in patients with hepatic fibrosis, right? In patients with the hepatic fibrosis, the serum concentration of the hyaluronic acid, it is being elevated. And what are the various non-invasive tests to diagnose the hepatic fibrosis is fibro test or the fibrosure. This is the non-invasive test. Apart from that, we have the fibroscan or transient elastography. Then the next one is magnetic resonance elastography. So these are the various non-invasive tests. And you see the next important question. A patient is being evaluated for jaundice and liver fibrosis. His AST is 87, ALT is 81. His serological tests are given below. Which of the following is the next step in the diagnosis? The options are HBV DNA level, anti-HBsAg, HCV RNA, RT-PCR, then the liver biopsy. So if you take the markers here, what is positive and what are non-reactive in these patients? IgM anti-HBC, it is non-reactive. IgG anti-HBC, right, that is positive. And HBsAg and envelope antigen, they are non-reactive. And anti-HCV, that is the reactive. So the patient is having the HCV virus. So now what is the investigation that you need to do for HCV virus is, you need to check for the HCV RNA levels. Now if the HCV RNA levels are elevated, and along with that your AST as well as ALT is also elevated, then you need to start the antiviral drugs. Now if if the HCV RNA levels are positive, whereas the AST and ALT, they are not elevated, right? AST and ALT, they are not elevated. When AST and ALT is not elevated, it is only when the HCV RNA levels are positive. Then what is that you need to do is you need to plan for liver biopsy, right? You need to plan for the liver biopsy. Now when the liver biopsy shows the signs of inflammation, right, when the liver biopsy shows the signs of inflammation, that is the point when you need to treat with the antiviral drugs, right? That is the point when you need to treat the patient with the antiviral drugs. So the answer here is the HCV RNA RT-PCR has to be done. Next question. Yeah. Now regarding the hepatitis B, right? Regarding the hepatitis B, what is the important serology that you have to remember? Now, the first important serological marker that will appear in hepatitis B is surface antigen. So, the surface antigen, it is the one which will be positive, and this is the first serological marker that will appear in the blood. And if the surface antigen is positive, what all it tells you? It tells you that the individual is having acute hepatitis B, or this will tell you that the individual is having the chronic hepatitis B, or this will tell you that the individual is a carrier. That is what is your HBsAg positive represent. Whereas if you take the anti-HBC, the anti-HBC, that is IgM anti-HBC, if it is positive, that is suggestive of the acute hepatitis B. And if IgG anti-HBC is positive, that is suggestive of the chronic hepatitis B. And please remember, HBC antigen, right? These two are what? These two are antibodies. Whereas the antigen to the core, that is HBC antigen, will never appear in the blood, right? Because the core antigen will be there within the hepatocyte, will never appear within the blood. Then another important serological marker will be anti-HBsAg. So if anti-HBsAg is positive, right? If anti-HBsAg is positive, this represents that the individual is cured. This represents that the individual is immune, right? And this represents that this individual, he is like completely cured of the disease, okay? And next important marker is HBeAg. The envelope antigen that tells you about the infectivity, right? That tells you about the infectivity and as well as the replication. So if the HBeAg, if it is positive, that tells that the individual is highly infective and the replication is also very severe. If suppose, if there is anti-HBeAg, the anti-HBeAg is there, that tells that there is low infectivity and as well as there is decreased replication, right? That there is decreased replication if anti-HBeAg is positive, right? And the next important is, apart from envelope antigen, next is HBV DNA levels. The HBV DNA levels, this will tell you about the quantitative replication of the virus, right? Quantitative replication of the virus. Whereas qualitative replication is represented by HBeAg. Quantitative replication is by the HBV DNA levels. So this is about the serology in case of the hepatitis B. And two more important things in the serology are, if suppose, if the patient is in window period, right? If the patient is in the window period. Now in window period, only IgM will be positive. Window period, this is also called as the gap period. So in window period or gap period, only IgM will be positive. Whereas if the individual is having a remote past infection, or if the individual is a low level hepatitis B carrier, it will be only IgG that will be positive, right? It will be only IgG that will be positive, whereas HBsAg and anti-HBsAg will be negative, right? So this is about the very important thing related to the serology of the hepatitis B. Now, let us discuss some questions. Which of the following virus is not transmitted by the percutaneous route? So we have two important viruses which are not being transmitted through the percutaneous route. One is the hepatitis A and as well as the hepatitis E. So hepatitis A and as well as hepatitis E, both of them, they are transmitted through the fecal-oral route. Right, both of them, they are transmitted through the fecal-oral route, both hepatitis A and as well as the hepatitis E. Whereas the hepatitis B and as well as the hepatitis D, these two, right, they are transmitted through the percutaneous route, they are transmitted through the sexual route, and they are transmitted through the vertical transmission. Right, they are transmitted through vertical transmission. So this is about the hepatitis B and as well as hepatitis D. But the one which is not transmitted through the percutaneous route is the hepatitis A and as well as hepatitis E. And one more important point is, among all the viral hepatitis, that is your A, B, C, D and as well as E, the hepatitis B is the one which is transmitted through, which is a DNA virus, whereas the remaining all viral hepatitis, that is A, C, D and as well as E, all of these are the RNA viruses. Right, all of these are the RNA viruses. It is only hepatitis B which is a DNA virus, right, which is a DNA virus. Okay, next question. Now, which of the following viral marker signifies the ongoing viral replication in the case of the hepatitis B infection? Anti-HBsAg, anti-HBc, envelope antigen and surface antigen. So this is what I was discussing in the previous question. So it is the envelope antigen, right, that tells you that the hepatitis B virus is replicating seriously. Okay, and envelope antigen representing the replication, it is the qualitative replication. Right, it is a qualitative marker, whereas quantitative marker is the HBV DNA levels. Quantitative marker is HBV DNA, whereas envelope antigen, it is the qualitative marker. Then you take anti-HBsAg, right? It is the antibody which represents that the individual is cured. And anti-HBsAg, this represents that it is an antibody, right? It is the antibody that is formed against the virus, that is IgG antibody and IgG anti-HBc in chronic infection, whereas IgM anti-HBc, that is in the acute infection. Whereas if you take the surface antigen, right, I said you, it is the first marker that will appear, and if the surface antigen is positive, that tells that the individual is having either acute infection or chronic infection, or the individual is a carrier, right? So that is about the envelope antigen. Next. Now a person is surface antigen positive but anti-HBsAg is negative, right? Or what should be the next best step? The options are: repeat the test after 6 months, check envelope antigen if positive, start the interferons, check the HBV DNA levels, then reassure the patient that he does not have any disease. So if surface antigen is positive, the individual is said to be having either an acute or chronic infection or a carrier. Now, the next step is you need to check for the HBV DNA levels. Now, if the HBV DNA levels are, if it is more than 2 into 10 to the power of 4 viral particles per microliter, then you should start the patient on the antiviral drugs. Right, you should start the patient on the antiviral drugs if the levels are more than 2 into 10 to the power of 4 viral particles per microliter. And what are the antiviral drugs? The antiviral drugs are, number one, the pegylated interferon. This was the drug which we were using previously, but the drugs that we are using presently are the entecavir, right? And the another important molecule is the tenofovir. Right? Another important molecule is tenofovir. So these three are the important antiviral drugs. But out of all these, the drug of choice will be tenofovir. Right? Out of all these, the drug of choice is tenofovir. So once the surface antigen is positive, then among the options which has been given to you, check for the HBV DNA levels. Otherwise, what we do once the surface antigen is positive is we need to check whether it is acute or chronic. That is it like IgG anti-HBC or is it IgM anti-HBC? That is what we need to check once the surface antigen is positive, because this will tell whether the patient is having acute or chronic infection. Because that is not there in your option, that is why I have just marked it as HBV DNA levels. Now if it is chronic, then only we give antiviral drugs. But if it is acute, right, if it is acute, we don't give antiviral drugs. It is just only supportive treatment. That is what we give if IgM anti-HBC is positive. Next question. Serology of the patient is given below. What is the diagnosis? Surface antigen negative. IgG anti-HBC, that is reactive, right? Envelope antigen, it is negative. And HBV DNA levels, that is undetectable. So what does this tell you? What is positive now? It is only IgG anti-HBC that is being positive. Now just now we were discussing if only IgG anti-HBC is positive, what does that tell you? So window period, then chronic hepatitis, recovery from remote infection, recovery from the acute infection. So in case of the chronic hepatitis, you should also have surface antigen that should be positive. Whereas to call it as the window period, what should be positive in case of the window period? IgM anti-HBC will be positive and surface antigen and anti-HBs AG will be negative. Whereas recovery from remote infection is the correct answer. So once the individual is recovering from remote infection, that is when you have the IgG being positive. Whereas acute infection, the individual will have the IgM anti-HBC being positive. So in remote infection, please remember, only IgG anti-HBC will be positive, whereas surface antigen and anti-HBs AG will be negative, and envelope antigen also will be negative. Next question. Maximum chance of spread in accidental needle stick injury is hepatitis B, HIV, hepatitis C, then Epstein-Barr virus. So now hepatitis B, hepatitis C, hepatitis HIV, they are spread through the needle stick injury. Now, what is the percentage of the spread with needle stick injury regarding hepatitis B is 30%. And what is the percentage of spread for hepatitis C? It is like 3%. And what is the percentage of spread in the HIV? This will be 0.3%. This will be 0.3%. Okay. So the maximum chance of spread in the accidental needle stick injury will be the hepatitis B infection, right? Next question. Why pre-transfusion testing does not increase the incidence of the hepatitis? Most carriers do not have surface antigen. Most transfusion hepatitis, it is caused by CMV. Present screening test is not sensitive for the surface antigen. HCV is not screened. So please remember, pre-transfusion testing does not decrease the incidence of hepatitis because the post-transfusion hepatitis, it is caused by the cytomegalovirus. And this cytomegalovirus, please remember, it can cause asymptomatic infection, right? And transfusion transmitted cytomegalovirus can cause problems in premature neonates, can cause problems in allograft recipients, and transfusion transmitted CMV can also cause the problems in splenectomized patients, right? Can also cause problems in splenectomized patients. So the answer here is the post-transfusion hepatitis, it is caused by the cytomegalovirus infection. So the next question is, patient with arthritis, skin pigmentation and hypogonadism is diagnosed to have the hemochromatosis, systemic lupus erythematosus, ectopic ACTH secreting tumor of the lung, then the Wilson's disease. So this particular patient is having the skin pigmentation, right? Arthritis and hypogonadism. It is a picture suggestive of the hemochromatosis. In patients with hemochromatosis, there will be excess iron overload, right? And this excess iron overload can occur in the skin, causing skin pigmentation, and that we call it as the bronzing of the skin, right? And in patients with hemochromatosis, we have a terminology called bronze diabetes mellitus. right? We have a terminology called bronze diabetes mellitus. And in case of bronze diabetes mellitus, there will be destruction of the beta cells, right? That will result in the type 1 diabetes mellitus. And in patients with bronze diabetes mellitus, there will be also accumulation of the iron within the liver, and that will result in the cirrhosis, and that will be micronodular cirrhosis, right? That will be micronodular cirrhosis. And in these patients, there will be bronzing of the skin. So this is a triad that you will observe in case of the bronze diabetes mellitus, all right? And in hemochromatosis, the gene that is being mutated, it is the HFE gene that is being mutated, and that is what is responsible for the excessive iron accumulation in multiple organs. And iron will also accumulate within the gonads, causing the hypogonadism, and will also cause the arthritis as well. Now, in case of the hemochromatosis, how will you diagnose is, for cirrhosis of liver, the important investigation is liver biopsy. So liver biopsy is the one which will confirm the cirrhosis secondary to hemochromatosis. Then what is the treatment that you need to give? The treatment options that we have is 1, phlebotomy, right? And another important option that we have is, if the individual is anemic, where you are not able to do phlebotomy, then you need to give iron chelating agent, and this particular iron chelating agent is the desferoxamine or deferriprone, right? Desferoxamine or deferriprone. That is what you need to give in case of the hemochromatosis, right? Next, and you take SLE. In patients with SLE, you will have the skin manifestations, and that skin manifestations will be in the form of the malar rash and as well as the discoid rash. And these patients will also have the photosensitivity, right? Will also have photosensitivity, that is in patients with the SLE. And in patients with SLE, please remember, the joint manifestations will be in the form of synovitis, right? Joint manifestations will be in the form of synovitis, all right? Then ectopic ACTH secreting tumor of the lung, that is small cell carcinoma. In small cell carcinoma, you don't have the skin hyperpigmentation. So what is that in case of small cell carcinoma that you will have is the respiratory manifestations, and these patients will also have hypokalemic metabolic alkalosis, right? And in case of Wilson's, this will be causing cirrhosis of liver, and that too macronodular cirrhosis, but you don't have the arthritis, skin hyperpigmentation as hypogonadism in case of the Wilson's. Next question. Hypertension with hypokalemia is seen in which of the following? Except the options are Cushing's, Liddle syndrome, end-stage renal disease, primary hyperaldosteronism. So the answer is the end-stage renal disease, because in end-stage renal disease, they will have hypertension, but what they will have is hyperkalemia, but not the hypokalemia. So they will be having hypertension with hyperkalemia. Whereas you take in case of the Cushing's. In Cushing's, what you will have is there will be hypertension, right? And they will be having the hypokalemia, right? They will be having the hypokalemia. Now, why is that these patients will have hypokalemia in case of Cushing's is because the steroids, when they are produced in excess quantity, they have the partial aldosterone activity. Right? They have the partial aldosterone activity. Which one? And what this aldosterone will do? They will cause the potassium excretion resulting in hypokalemia. Now, Liddle's. What is this? It is a genetic disorder which is characterized by an autosomal dominant type of inheritance. And in case of Liddle's, which is an autosomal dominant type of inheritance, there is gain of function of the ENaC. Right? There is gain of function of the epithelial sodium channels. And because of gain of function of epithelial sodium channels, there will be increased sodium and water retention, potassium excretion, and as well as the H+ ion excretion. Right? And that will result in the hypertension and as well as hypokalemia. That is in Liddle's. Whereas in primary hyperaldosteronism, the clinical picture will be same because aldosterone will also be causing the sodium and water retention, potassium and H+ion excretion. And if you take the littles, this is one important topic where you have gain of function of the ENaC channel. What is the drug of choice? You need to block this ENaC channel. And what is the drug that will block the ENaC channel is the amiloride. Okay, so amiloride is the drug that will block the ENaC channel, and thereby the activity of the sodium and water retention, potassium excretion and H+ion excretion does not occur. Okay, so so the scenario where you will not have the hypokalemia is end-stage renal disease, because whenever there is an end-stage renal disease, the potassium excretion does not occur, and that will result in the hyperkalemia, right? Next question. Now, which of the following abnormality is shown in the ECG given below? The options are the ventricular fibrillation, ventricular tachycardia, ventricular bigeminy, artifacts. Now, if you take the ECG, what is the description of this ECG? First and foremost, there is tachycardia, right? So the heart rate, it is around 300 per minute. That is the first point. Second important point is, if you take the P wave, the P wave is absent. So P wave is absent means the origin of the impulse is not from the atria, the origin of the impulse is from the ventricle. And you have the presence of the wide QRS complexes. So P wave absent and wide QRS complex and tachycardia, and that too. And how is the rhythm? Regular rhythm, right? Rhythm is the regular rhythm. So regular rhythm, P wave absent, wide QRS complex, tachycardia. What is it suggestive of? This is suggestive of monomorphic ventricular tachycardia, right? Monomorphic ventricular tachycardia. Whereas in ventricular fibrillation, what is the abnormality that you will have is there will be no identifiable, right? There will be no identifiable QRS complexes, right? There will be no identifiable QRS complexes in case of the ventricular fibrillation. Whereas in ventricular tachycardia, this is what is the ECG. Then you take ventricular bigeminy. In case of ventricular bigeminy, one will be a normal QRS complex, right? And exactly the alternate will be the wide QRS complex, right? The exactly alternate QRS complex will be the wide QRS complex. So in ventricular bigeminy, the alternate QRS complexes, they are wide with absent P wave. Right, but here if you observe, all the QRS complexes are wide, so this is not your ventricular bigeminy, and it is not the artifacts as well. So the answer here is the ventricular tachycardia, and that too a monomorphic ventricular tachycardia. Now, how will you approach for the treatment of the VT? In case of VT, the first important thing that you need to check for is the presence of the hemodynamic stability. Right, the presence of the hemodynamic stability. So if at all, if the hemodynamic stability is present, then the drug of choice will be the amiodarone, right? Then the drug of choice will be amiodarone. If at all, if the hemodynamic stability is absent, that means if the individual is hemodynamically unstable, right? If the individual is the hemodynamically unstable, then you need to give the DC shock, right? Then you need to give DC shock. And what is the strength of the DC shock? That should be around 300 to 360 joules is what you need to give in case of VT. Whereas if you take the treatment in case of VF, most of the times these patients are hemodynamically unstable and they will be requiring the DC shock, right? They will be requiring the DC shock. So which of the following abnormalities is shown in the ECG? That is VT. And the treatment is, it all depends upon the hemodynamic status of the individual, right? Next question. Now, the pattern shown on the following flow volume loop is the obstructive pattern, restrictive pattern, the normal curve, or the mixed pattern. Now, see, this is the pulmonary function test in which the lower side of the graph, it represents the inspiration. The upper side of the graph, it represents the expiration. And if you take the normal curve should be up to here, right? The normal expiratory graph should be up to here. Whereas in case of the obstructive pattern, right, in case of the obstructive pattern, what will happen to the expiratory component? The expiratory component will be reduced. Right, the expiratory component will be reduced in case of the obstructive pattern. So the answer is obstructive. Whereas you take in case of the restrictive pattern, it is both the inspiration will be reduced and as well as the expiration also will be reduced. Right. So this is what you observe in case of the graph which is given is of the obstructive pattern. Whereas this is what is your normal flow. Right, normal flow. And what has been given in our question? So in our question, right, this expiratory pattern was reduced. Okay, whereas you take this green color markings where the inspiratory component is also reduced and as well as the expiratory component is also reduced. This can be seen in case of the inspiratory pattern of the pulmonary function test, right? And what are the causes for the obstructive lung diseases and what are the causes for restrictive lung diseases? So if you take the etiologies that will be causing the obstructive lung diseases, that will be your asthma, then bronchitis, then bronchiectasis, then cystic fibrosis, then COPD. So these are the causes for the obstructive lung diseases where you have the obstructive pattern on the spirometry. Whereas if you take the restrictive lung diseases, right, restrictive lung diseases, we classify that into the pulmonary and as well as the extrapulmonary causes for the restrictive lung diseases. So pulmonary causes for restrictive lung diseases will be sarcoidosis, right? Sarcoidosis, then pneumoconiosis, right? Sarcoidosis, then pneumoconiosis, then interstitial lung disease, then drug-induced fibrosis like the amiodarone will cause the fibrosis. Then what are the extrapulmonary causes for restrictive lung diseases? That includes obesity, that includes kyphoscoliosis, right? That includes the ankylosing spondylitis, that includes myasthenia gravis and as well as the Guillain-Barré syndrome. So these are the extrapulmonary causes for the restrictive lung diseases. So this is about the pulmonary function test. Next question. Now, the image shown here represents or shows the presence of swan neck deformity, Bottomley's deformity, mallet finger deformity, the Dupuytren's contracture. So the image shows here, it represents the mallet finger deformity. Now what is the abnormality that you are having here? It is only the distal interphalangeal joint, you have the flexion. Right, you have the flexion only in the distal interphalangeal joint. Whereas if you take the metacarpophalangeal joint and as well as the proximal interphalangeal joint, both of them are normal. So that tells it's a mallet finger deformity. So this mallet finger deformity, it is secondary to trauma. Right, it is secondary to trauma. And what is the, or where exactly will be the trauma? It is, the trauma will be to the, right, trauma will be to the tendon which is inserted over the distal phalanx. And that too, what is the tendon? That is the extensor tendon. Now, because the extensor tendon is being ruptured, then the distal digit, you will have the flexion. Right, in the distal digit, you will have the flexion. Okay. Now, you take the swan neck deformity. So in case of this swan neck deformity, Bottomley's deformity, that you see in patients with rheumatoid arthritis. That you see in patients with rheumatoid arthritis. And in case of swan neck deformity and Bottomley's deformity, what is the abnormality within the joint? It is again small joint deformity in rheumatoid arthritis. So how will be the PIP and how will be the DIP? So in case of swan neck deformity, in the PIP, there is increased extension. There is increased extension in the PIP. And whereas in DIP, you will have the flexion. Right? In DIP, you will have the flexion. Whereas you take Botany's deformity. It is exactly the opposite. In case of Botany's, you will have flexion in the PIP, whereas extension in the DIP. Right, extension in the DIP. So this is what is your Botany's deformity. So both of these deformities are seen in case of rheumatoid arthritis. Whereas you take Dupuytren's contracture. Dupuytren's contracture is that where there will be fibrosis of the deep palmar fascia, right? And because of the fibrosis of the deep palmar fascia, these patients will have the flexion, right? These patients will have the flexion or flexural contractures will be there of the palm. That is, and where do you see this Dupuytren's contracture? You see that in patients with cirrhosis of liver, right? Cirrhosis of liver. Okay. So the answer here is what? That is mallet finger deformity, which is occurring secondary to trauma. Next question. Yeah. So this is what is your swan neck deformity, which I was discussing, that there will be hyperextension at the level of the PIP and flexion at the level of the DIP, right? Whereas you take in case of the Botany's deformity, in Botany's there will be flexion at the PIP, extension at the DIP. And in mallet finger deformity, you will have only flexion at the distal interphalangeal joint. And Dupuytren's contracture, you can see that there will be fibrosis of the deep palmar aponeurosis, and that you see in patients with cirrhosis of liver. Next question. A patient with hypertension presents with the following skin lesions. What is the diagnosis? The options are livedo reticularis, anaphylactoid purpura, drug-induced rash, erythromelalgia, right? So the image shows the presence of reticular net-like appearance. Right, reticular net-like appearance. Now, where is that you observe the presence of the reticular net-like appearance? You see that in the scenario of the livedo reticularis. In livedo reticularis, you have this, the reticular net-like appearance. Now, what are the conditions where you can have the development of livedo reticularis is in patients with atheroembolic diseases. Right, in patients with the atheroembolic diseases, you will have the reticular net-like appearance. Right, next question. Non-contrast CT shows the presence of left intraventricular hemorrhage, right intraventricular hemorrhage, left intraparenchymal hemorrhage, right intraparenchymal hemorrhage. Now, what is this CT showing? It is a hyperdense lesion. Right, the CT scan, it is showing the presence of a hyperdense lesion, and this particular hyperdense lesion, it is present. See, this is the right side and this is the left side. So it is a left, and it is not in the ventricle. So this is the parenchyma part of the brain. So you are having left intraparenchymal hemorrhage, right? Left intraparenchymal hemorrhage. That is what, and which part of the parenchyma? That is left frontotemporal area. Right, left frontotemporal area, you have the presence of the hemorrhage. So it is left intraparenchymal hemorrhage. Next. Now, which of the following is correct about the non-contrast CT shown below? Acute ischemic stroke, then acute hemorrhagic stroke, subarachnoid hemorrhage, and then the intraparenchymal hemorrhage. So, what is that you are observing here is, you are observing the hypodense lesion, right? Let me just zoom this. So, this is the excessively dark in the parenchyma. So, this is, right. So, this is hypodense lesions. Now, where do you have the hypodense lesions? Hypodense lesions are observed in case of the acute ischemic stroke, right? In case of acute ischemic stroke, you have the hypodense lesions. Whereas hemorrhagic stroke, you will have right, you will have the hyperdense lesions. Whereas in case of subarachnoid hemorrhage, in subarachnoid hemorrhage, you have the presence of the hyperdense lesion within the sylvian fissure. You have the presence of blood in the sylvian fissure. That is in case of the subarachnoid hemorrhage, right? And next question. Now, the test being performed on the patient shows the fluid thrill, puddle sign, shifting dullness, and then the flank dullness. So, what is the test that is being performed here? Now, if you observe very closely, now two examiners are performing this test, right? That is, one examiner has placed the hand in the center of the abdomen, and the other examiner, by using the two hands, right, by using the two hands, is applying like a tap over the flank. And if you take the abdomen, it is distended. So what exactly is this? This is a patient who is having ascites, right? And the test that is being done is the fluid thrill, right? Now, what are the other options then? Depending upon the severity of the ascites, the demonstration of the ascites can be done by various methods. Now, if you take normally, right, normally the peritoneal cavity does not have the fluid, right? Normally the peritoneal cavity fluid is zero, right? Both in men and women. Only in females during mid-ovulatory cycle there can be up to 20 ml in the peritoneal cavity, right? And when the quantity of the fluid is like more than 100 ml in the peritoneal cavity, that we call it as ascites. That can be diagnosed or that can be demonstrated by the puddle sign. That is number one. Or this can also be demonstrated by the ultrasound of the abdomen. So puddle sign and as well as the ultrasound abdomen, that will demonstrate the presence of the fluid like more than 100 ml within the peritoneal cavity. Now, when the quantity of the fluid, if it is around 500 ml in the peritoneal cavity, you will have the shifting dullness, right? You will have the shifting dullness, right? And when the quantity of the fluid, if it is around 1000 to 1500 ml, if the quantity of the fluid is around 1000 to 1500 ml, that is the point when you will have the fluid thrill, right? You will have the fluid thrill. Okay, so the puddle sign is, fluid thrill you will have when the quantity of the fluid is around 1000 to 1500 ml, puddle sign 100 ml, shifting dullness around 500 ml. Okay, so what is being demonstrated here is the fluid thrill. And we also have another important terminology called tense ascites. Tense ascites is that where the quantity of the fluid in the peritoneal cavity will be more than 2 liters, right? The quantity of the fluid in the peritoneal cavity will be more than 2 liters. And when the quantity of the fluid in the peritoneal cavity is more than 2 liters, please remember the fluid thrill will be absent. Right, the fluid thrill will be absent in cases of the tense ascites. Okay, so the answer here is the fluid thrill. Next question. The clinical sign below denotes tetany, tetanus, median nerve palsy, and then the radial nerve palsy. So what is that you are observing here is there is carpal spasm, right? And there is flexion at the wrist. There is also flexion at metacarpophalangeal joint, right? Flexion at the metacarpophalangeal joint, and there is extension, right? And there is extension at the level of the interphalangeal joints. There is extension at the level of the interphalangeal joints. So what is it suggestive of? This is tetany. And where do you come across this particular tetany? This tetany, right? Where do you come across this tetany? This tetany, it is the feature that you will have in patients with hypocalcemia, and this hypocalcemia can occur secondary to hypoparathyroidism. Right? Hypocalcemia can occur secondary to hypoparathyroidism. Then what are the other features that you will have in case of hypocalcemia apart from tetany is there will also be perioral and as well as periungual paresthesias. Right? Perioral and as well as the periungual paresthesias. That is what you will observe in case of the hypocalcemia. And in case of the hypocalcemia, these patients, what is the cause of death? That would be because of laryngospasm. Right? The cause of death will be, right? The cause of death will be laryngospasm. And you need to demonstrate the serum calcium levels to see that or to tell that there is hypocalcemia. And next important is the treatment. So the treatment that you should be giving in these patients is the calcium gluconate. Right? The treatment that you need to give is the calcium gluconate. Okay. So the answer here is the tetany.